Hello everyone, my name is Skylar McLean. I'm a first-year pharmacy resident at M Health Fairview, and I had the opportunity for my longitudinal project to work with BMT patients. So with that, the title of my research project is Outcomes After Allogeneic Stem Cell Transplant Status Post-Sirolimus, Post-Transplant Cytoxin compared to Tacrolimus. So jumping into things, just kind of a brief background as to why we are doing this study. Immunosuppressant drugs are a cornerstone in the management of allogeneic stem cell transplants, particularly for preventing graft versus host disease during the critical period prior to engraftment. Calcineurin inhibitors, such as cyclosporin and tacrolimus, have traditionally been the backbone of immunosuppressive therapy in this context. However, these agents are associated with significant side effects and present challenges related to dosing and therapeutic drug monitoring. So there has been this need for alternative immunosuppressive strategies that has led to a growing interest in agents like sirolimus, which is known for its distinct mechanism of action and synergistic potential when combined with other immunosuppressants. For this study, we will be doing single-center retrospective study comparing the administration of sirolimus, mycophenolate, and PT-Cy, and comparing that to tacrolimus in patients receiving allogeneic stem cell transplant in the inpatient setting with a minimum of 100 days post-transplant. As far as the objectives of this study, our primary objective is going to be to evaluate the time to engraftment at days 30 and 100 post-transplant. And we're going to be doing this by defining it as an absolute neutrophil count, or ANC, that's greater than 500 for 3 consecutive days. As far as secondary objectives in this study, we'll be looking at drug levels and GVHD occurrence, as well as adverse events, some of which are common to both tacro and sirolimus, such as cytopenia and hypertriglyceridemia, but we're also interested in unique side effects occurrence of sirolimus, such as acne, pericardial effusion, and wound healing impairment. And we'll also be looking at a need for additional infusions, and this is platelets and magnesium. In the infusion world, they often say chair time is money, and if we can find a difference between tacro and sirolimus and patient needs to be infused, there might be a cost-saving benefit to that as well. As far as methods go, our inclusion criteria is all from our BMT studies. Patients, when they are enrolled in transplant, have to meet this criteria. So we're looking at an age and performance status somewhere between 0 and 70 years, with a Karnofsky that's greater than 70%, or a Lansky that's greater than 50% if they're less than 16 years of age. However, patients aged 70 to 75 can also be eligible if they have a hematopoietic cell transplant comorbidity index of less than 2 to be eligible. As far as previous transplants, they have to be greater than 3 months post-myoablative transplant, if applicable. And for the allogeneic stem cell, they have to have a donor match of 5 out of 6 or 6 out of 6 for a related donor, or 7 to 8 out of 8 HLA matched for unrelated donor. Eligible diseases include acute myeloid leukemia, acute lymphoblastic leukemia, chronic lymphoblastic leukemia, small lymphocytic lymphoma, plasma cell leukemias, myeloplastic syndromes, chronic myelogenous leukemia, lymphoma, and myeloproliferative syndromes. As far as organ function, and I apologize for my camera cutting off the bottom right corner here, they need to have adequate liver, renal, cardiac, and pulmonary function, as well as normal AST, ALT, and creatinine of less than 2, and an absence of any severe organ dysfunction. And with that, our exclusion criteria is patients may not be pregnant or breastfeeding. They can't have any active infections, untreated active infections, or any CNS disease. The patient cannot have active HIV infection or any known HIV positive status. Some prior treatment limitations are a history of congenital bone marrow failure syndrome, any prior radiation precluding TBI or CML in refractory blast crisis, And as far as disease progression goes, progressive, intermediate, high-grade NHL, or Hodgkin's lymphoma or multiple myeloma on salvage chemotherapy. As far as the results we're hoping to find, currently we're still in the data collection phase and chart checking the patients. We hope to identify an alternative regimen with comparable efficacy. This is to evaluate the potential of sirolimus and PT-Cy, as well as an alternative to Tacro, ensuring it delivers similar or better outcomes in terms of engraftment and GVHD prevention. We also would like to assess the tolerability and severity of adverse effects and compare the safety profiles of sirolimus and tacrolimus, focusing on differences in frequency, severity, and types of adverse events experienced by the patients. And we also hope to evaluate cost savings from differences in infusion requirements, quantifying potential cost savings associated with the need for fewer additional infusions or interventions in patients receiving either sirolimus or tacrolimus, factoring in drug administration and management costs. As far as the future direction that I hope this project will lead to is just the study to contribute to refining and optimizing the treatment algorithm and enhancing patient outcomes and care strategies. So in conclusion, with my project, I'm looking at sirolimus and post-transplant Cy, and I'm hoping that it offers a potential alternative to tacrolimus for immunosuppression in stem cell transplant. We'll be monitoring for differences in safety profiles and adverse events. We'll evaluate cost effectiveness that may favor sirolimus due to fewer infusion requirements. But as always, future research is needed to optimize treatment protocols and improve patient outcomes. And with this study, I hope we can add to that. Thank you, and I appreciate your time.